Introduction, respected chairpersons, discussants, senior faculty members, teachers, and colleagues. After hearing the scenarios, the master talks by everybody here, I feel humbled to be standing in front of you, not because I know more, but because I have listened more than what it is there in store. And everybody said it right. Coming to a conference to gain knowledge and reading from a computer is something different. You can gain a lot of knowledge from the computer itself, but listening to experts and gaining their wisdom, so listening to their wisdom gives you knowledge to help you gain wisdom in your practice, and that's what the key would be. And also the camaraderie of all the people here will increase the lifespan, I suppose, as told by Dr. Hiramat. So with that words, I'll start. Bradycardia, I think the lesser the heart rate, more the lifespan. But why do you want to treat it then? You should not treat it, right? So unless the patient is symptomatic, you don't treat sinus bradycardia. Unless the patient has problems, you don't treat. So my talk would be divided into three major parts: case scenarios and recent advances, and a takeaway message. True bradycardia is only sinus bradycardia and AV block. You cannot have bradycardia because of anything else. Pseudo bradycardia in the current world is because of all the digital devices. It can be APC driven, VPC driven, under sensing of your smartwatches causing bradycardia, sensing the sleep bradycardia as pathological bradycardia. So all those things put together make you a little bit tense. Pathological bradycardia is what we treat if the patient has symptoms. So a typical case of bradycardia, sick sinus syndrome in the elderly since long, and with a normal echo, the patient comes to you with symptoms, you treat that. A patient with AV block, here is 2:1 AV block, no chest pain, normal echo, occasional giddiness, so symptomatic bradycardia, you treat the patient by a typical pacemaker, single chamber pacemaker, double chamber pacemaker, or if LV dysfunction is there, a CRT. Right? That is how we treat, general. So what is the challenge? Why do you want to have that challenge of getting into bradycardia? 90% of cases are these typical cases. Normal routine clinical practice is 90%. So I was given a challenging topic. So I'll put in the case scenarios. What is the challenge? So what causes bradycardia? Is it degenerative or is it something else? What are the treatment that can be offered in bradycardia, and what is the type of device in the current scenario that you have? So let us see in case presentation that come to your clinical practice. This is a patient who presented with symptomatic bradycardia since last 5 years but not wanting to get treated. Ejection fraction was 45%. There was pulmonary artery hypertension, restrictive cardiomyopathy possibly, and patient had symptomatic failure. So what do you do with this patient? You will say, put in a pacemaker, right? Simple, straightforward. So, doing a Holter, get some idea of the average heart rates. Doing a cardiac MRI possibly would tell you that this is the cause. But however, the patient has symptoms because of bradycardia, so you want to do a pacemaker. So, why to evaluate further would be to decide on what kind of pacemaker. And so the treatment options in this bradycardia was what to do. So, whether to give a single chamber pacemaker with normal routine septal pacing, with a conduction system pacing, single chamber pacemaker, or a single chamber pacemaker with atrial pacing, or a double chamber pacemaker in the similar fashion, or a CRTP. So what do you suggest? Seeing the history of this patient who has atrial fibrillation, bradycardia, what would you want to give? So think that atrial fibrillation is there since long, you don't want to pace the atrium at all. So obviously you have to pace only the ventricle, and if you are pacing the ventricle with an ejection fraction of 45% with the septal pacing, you might worsen the LV function. That is what people have shown over trials, wherein wider the QRS, the chances of LV dysfunction is higher. So what is conduction system pacing? And I'll just give you a purview of that you try to pace the conduction system itself. You pace the His-Purkinje system either at the level of the His or below that at the left bundle or near the higher septal where you can capture this his Purkinje system easily, and that will give you the normal conduction that happens via the normal system. Normally, if you are pacing, you will be pacing in the RV apex or the septum mid. Rather than that, you are pacing at the conduction system, and we use special hardware, and you need to have special techniques for that, and preferably a 12 lead ECG during the implant. So for this patient who needs a pacemaker, most of the time, if you do a pacemaker in a patient who has an ejection fraction less than 50%, what is recommended is you do a conduction system pacing or a CRT rather than a typical pacemaker. So that is one thing that you should know as a class 2A indication. In atrial fibrillation, similarly, if you do a AV nodal ablation or if you have bradycardia, a conduction system pacing or a CRT is advisable. So what is conduction system pacing? Just a single lead here put in the septum and you will see the outcome. This is the own rhythm and we started pacing. It hardly has a difference. It's narrow, complex, typical. It will give you a very good normal looking narrow complex with good stable output. So over 3 years this remains the same and the patient ejection fraction has not worsened. The pacemaker is working fine, and with a single chamber you are able to achieve what CRT would achieve with 3 leads. So that is the cost saving also. This was way back in 2012 when the ejection fraction in this patient was around 50%. Treated as primary pulmonary hypertension, bradycardic, no P wave seen, and this turned out to be atrial standstill. The heart rate would not improve, the atrial was stiff, and that is why pulmonary hypertension was there. We just did a CRT in this patient with the RV and LV lead, and the patient, we did a PG change in 2021. She is now 80 years old. Otherwise remained symptom free. What she was functional class 3 is now functional class 2 over the 10 years of her aging. Going on to the next part would be AV block. So if you have an AV block, you put in a double chamber pacemaker and you are done. But if patients have ejection fraction which is around 50% or low, if you have an LV dilated and dilated heart with a valve regurgitation, better is to do physiological pacing, and that is where conduction system pacing again comes. A double chamber pacemaker, if you do, the outcome looks like a normal conducting person only. So that's very important to get that the LV doesn't dilate it. So now I will get to the next part. What after conduction system, what comes? So if you have a patient who has palpitation and along with that fatigue, you have tachybrady syndrome, you have one place tachycardia, one place bradycardia, what would you do? Normally, the options would be give antiarrhythmic medications and see that the tachycardia doesn't occur. But if you give antiarrhythmic, the bradycardia will be more, right? So then people would say, no, give a pacemaker and then give medications. But how guaranteed you are to treat the patient of tachycardia with medications? So therefore, the role of ablation comes here. We treat the patient with tachybrady syndrome. If it is ablatable, we treat with ablation first. And in this patient, we did a 3D map. Showed that there was a scar. So the gray part was all scar in the right atrium and the colorful part that you see were scar areas a little bit, and we treated the patient for tachycardia. After tachycardia was treated, he continued to be in bradycardia, 45 average heart rate. He was advised a dual chamber pacemaker just because he had a scar and the chances of recurrence of tachycardia was there. But he was reluctant because now the tachycardia settled, bradycardia is well tolerated, and therefore he continued for 2 years on dabigatran and derifylin to keep his heart rate up. Again in 2024 he presented with palpitations, and that is where he again had symptoms. So echo was showing mild more RA dilatation. We wanted to see an MRI. MRI showed no LG. So now again what do we do? Now give a pacemaker or again go for an ablation? So main problem is tachycardia. I want to treat the tachycardia, so I went again for an ablation. And if you see, the scar has progressed and the RA has dilated much more than what it was before. So this is a progression of disease. And if you see, there is no living muscle in the whole of the right atrium. So suppose if I would have done a pacemaker, it would not be pacing now the right atrial appendage at all because there is no signal in that area. there would be no pacing at all in the atrium, and I would have ended up doing a ventricular pacing in this patient. So there is no capture at all in EP study, and the average heart rate post ablation was around 42 only. So we did do a pacemaker, dual chamber pacemaker, but no atrial pacing. Therefore, we had to do a left atrial pacing. Left atrial pacing was done by a epicardial pacemaker put on the left atrial appendage. So it was a simple procedure, 45 minutes of thoracotomy, and this will give you more insight as to how to operate, because many a times you will say, no, the lead failed. No, it's not the lead failed, it's the disease which progressed. Coming on to the other part, wherein you need to find out what is the cause, very important. So garden variety complete heart block, but in a young patient, 52. Why should a 52-year-old have a complete heart block? And that too with TROP positive and angiogram being normal. So something wrong has to be there, and that wrong has to be seen. But if a patient has long pauses with pre-syncope, our reflex is to put in a pacemaker. So we did see the echo. We saw that there was no RWMA, no chest pain, and we did put in a pacemaker. But evaluation further we did, and what did we find? So after discharge, it was very important to say, no, we need to evaluate further. And that evaluation led to a PET scan which showed that there was an uptake, abnormal uptake into the myocardium in the infralateral area, suggestive of possible sarcoid heart disease. Now, I would have treated by a pacemaker, but the sarcoidosis is not treated, right, by pacing, and that's very important. Managed with steroids and methotrexate later on, and after 3 months there was no uptake at all. So treating the disease per se is very important, and the next example will show you why. Again, a 28-year-old presenting with complete heart block or high grade AV block, symptomatic but not wanting a pacemaker. We evaluated, PET scan was positive, again a single nodule there. We asked him to get a pacemaker done, but he was delaying again and again. But if you have patients who have not been put in a pacemaker and you want to plan this patient a pacemaker, the recommended therapy is a dual chamber ICD. Why? Because sarcoid heart disease can cause ventricular arrhythmia itself. And no matter, we could see in this patient itself that he did not agree for an ICD, and we put in a pacemaker. Echo was still normal, but he had VT on the patient's follow-up. So he had a clinical VT on a patient on follow-up. We did a PET scan again. PET scan showed increase in the uptake. We had advised steroid, but then he said, I did not take steroid because it was my marriage that time. So he did not take steroids. He failed to take the treatment for sarcoids. He ended up with a VT. So if you don't treat these patients early enough, they end up having more disease, and later on they also may develop LV dysfunction further. So this was a patient who had a pacemaker done, EF was noted normal, everything evaluated, was then noted LV dysfunction within 2 years. Ejection fraction had decreased to 35% on follow-up. And if you see the PET scan, the whole of the anterior wall was showing an increased uptake. By the time we intervened by doing a CRTD, the damage was done and the ejection fraction still remains at 35%. So very important to see the cause rather than just see why the patient has had bradycardia. It's very important to see the cause. In a young lady, 52, weight loss as a typical feature, fatigue can be there. But if you see ECG characteristics, there is T-wave inversion. So these T-wave inversions are abnormal for a sinus bradycardia per se. So that is AI. By experience, by seeing more patients, by seeing their follow-up, you gain much more knowledge, and that is what helps you to treat those patients. And we did a MRI which showed an infiltration here and a PET positive, but she had a breast nodule also. It turned out that the patient had a breast CA with metastasis causing the sinus bradycardia. So the first presentation of sinus bradycardia was this breast metastasis. She had flutter, she had loss of pacing later on, and she eventually did not make it this last year itself, but then we could diagnose what caused the problem. Another lady, again diagnosed to have 6 sinus plus AV block, and she had a pacemaker done. Ejection fraction decreased to 35%. over a period of 1 year, it was considered that you have paced and therefore LV dysfunction has set in. So she also had atrial flutter, and if you see that pacing interrogation had continuous flutter, referred for ablation of flutter as well as treatment to upgrade to a CRT. Now we did a PET which came to be normal, but ESR was very high, 98. Did the ANA profile which showed high values of SSA-RO, and then just steroids were given for the patient and ejection fraction improved immediately. So rather than CRT, just a steroid dose for this SLE treated the patient. Again, bradycardia treated for, referred for pacing and had syncope and sweating and vomiting, and we did the HUD test which was having a long pause. So how many would put a pacemaker in this? I think everybody agrees that everybody would. But what is more important is the tummy ear of the patient, and if you see that with bradycardia and Holter, and if you see the Holter recording, it's all night time between 10 o'clock and 4 o'clock in the night, where there were long pauses, and that was classical of sleep apnea. And if you treat sleep apnea, 2001, that was the presentation, 63 heart rate. He continues to be on follow-up till 25, last follow-up 17th, yesterday only, I suppose. And CPAP and weight reduction, these are the two things, no symptoms, no pacemaker, continues to be fine. So treatment of sleep apnea treats the patient symptomatically rather than treating the bradycardia itself. So very important, whom to evaluate for secondary causes are females, acute history, patients who have abnormal brady as well as tachycardia, systemic features are there, skin lesions are there, patients who are obese with sleep apnea and high inflammatory markers, they should be evaluated further. A word about the guidelines. Guidelines are there, but you don't know them. So there we know anybody with less than 60 years with AV block should be evaluated by at least a CT scan, if not by MRI or a PET scan. So it's very important, and these are part of the guidelines. So genetic testing as one more part. Bradycardia, 6-year-old boy diagnosed as long QT, just treated with propranolol. So bradycardia treated with propranolol because the patient had long QT causing torsades, causing syncope. You would have thought that bradycardia was causing the, again a patient, again 15-year-old boy, treated as sick sinus syndrome, multiple years of evaluation, bradycardia persisting, symptoms persisting, and Holter showing long pauses, thought to be post-viral sequelae, and MRI also done which did not show any sequelae, and again Holters were repeated. But finally you should understand that long-standing history in a young person can be genetic in nature, and when we asked for genetic testing, especially that SCN5A and Desmin, it came out to be SCN5A mutation. Now when you have this mutation in this patient, you know that this is a progressive disease and the treatment should be accordingly rather than a post-viral disease. So knowing why this happens is very important to further answer these questions, whether it will progress and what kind of pacemaker the patient would require, because it will progress, the atrium will get burnt out and you might require a conduction system pacing in that. One more patient, young patient, see epilepsy in children and not getting treated is a arrhythmia underlying, and that is where this child was there, 2:1 AV block. We did a pacemaker with AV block, but post you can see that there was ventricular arrhythmia, and even after that the patient unfortunately had a demise. Why? Because the patient had a myosin heavy chain mutation, which was not recognized before putting in the pacemaker. We could have put in an ICD itself. So it's very important to evaluate well. Similarly, post pacemaker patient develops ptosis and has a Desmin mutation, very important. So these are patients who will present with atrial flutter and LV dysfunction later on, and you need to put in a CRT. Lastly, these advances in bradycardia therapy. If you have patients with infection or a closed venous system, you can go in for an endocardial with venoplasty. You can do from the femoral vein, You can go transhepatic, you can go transjugular, but what is in is the leadless pacemaker, which can be implanted through the femoral, and it's a battery operated small capsule type which goes into the right ventricle, just paces down, and it is now in a VDD format as well as a double chamber format. You can pace the atrium well, you can pace the ventricle both simultaneously. Indications being infection, subclavian stenosis, so lead access is not there, and tricuspid valve disease as the major indication. And for FADS, physician choice, people say, no, I've done a leadless pacemaker. So advantage and disadvantages are there. Problems are also there. There is what we call as a YCRT, so you implant a capsule somewhere and it ablates. Last, about home monitoring, bradycardia treatment. You can monitor without going to the hospital. You can do it on your mobiles, and mobile connected pacemakers are there which will transmit all the data to your treating physician, and then they will say it's right or not. So summarizing, bradycardia is treated easily by pacemaker. Most of the cases do not have secondary causes. And mind you, 90% don't have secondary causes. Only 10% will have to be evaluated, and especially young patients are to be evaluated well. Knowing the secondary cause is important to go further as to how to treat them in the future, as well as which device to be given, and indications of these devices should be known well, especially the leadless and conduction system pacing, rather than do it in all. Thank you.